Welcome to this series of interviews with the giants of cardiothoracic surgery. My name's Joel Dunning and I'm here at EACTS in Geneva with Professor Tom Treasure. Professor, you've been president of EACTS, you've been on the NICE guidelines for the treatment of lung cancer, you've been editorial chairman of the ESTS lung metastasectomy project. You did an amazing job getting the Mars trial off with extreme difficulties of recruiting, and yet you got them through that. And also what I'd really like to talk about now is metastasectomy, because you're starting a trial to really give us a lot of the answers that we're not going to be able to address in this interview. But first of all, I would like to talk through some of the issues of metastasectomy for you. And from a personal point of view, I wanted to start off by asking perhaps an example of a patient that I'd had recently. I was there with a 71-year-old gentleman. He'd had colon cancer 2 years previously. He came to me with 2 metastases in the right lower lobe. He's a lawyer and he's very well informed, and he wanted to know, will he benefit from an operation? What would you tell somebody like that?
Well, the answer has to be that we don't know, and I'd certainly be wanting to recruit a patient just like that into a randomized trial, and I'll tell you why. There is a serious mismatch at the moment, and this applies to patients such as him, between the best evidence available and the consensus of current practice. Now, you told me that this was a 2-year interval. Well, in the most recent information from Memorial Sloan Kettering, that's a Natus paper 2009, there's a very clear indication that 3 or more metastases predicts patients who will not do well. So at 2, he just creeps under that barrier. It also says quite clearly that patients under 1 year do not do well. That is, none of them survive long term. Now, so there's 2 things: the interval between the primary and the secondary, and the number of metastases. Meanwhile, the ESTS consensus from the survey showed that 64% think that an interval of less than 1 year doesn't matter, and 85% are very happy with multiple metastases. So they're clearly operating on a group of patients in whom available evidence, which is in itself is very limited, as I'll go on to explain in as much detail as you want, would suggest these patients cannot be helped. Now, to come back to your patient, there is no evidence that surgery in that patient alters the outcome, and I don't mind explaining why. But what we do know is if he has only 2 metastases and there is an interval of 2 years, he might be a long-term survivor. But whether that's due to the natural history of that pattern of disease or to the surgical intervention is what we'd really like to find out.
And in that patient, what do we have evidence-wise to tell him? There's some evidence, isn't there, that sort of say R1 resections, they will live less long than R0, but how can I persuade him to have an operation currently? How strong is the evidence right now?
I wouldn't persuade him. I would tell him that it's unknown, but say that the most useful thing we can all do, that includes patients and us, is to find out. Now, what we know is based on a whole series of retrospective reports, the classical retrospective surgical case series. And we've published a systematic review with a quantitative analysis on this. And we've got 51 51 papers giving a total of 3,500 patients. And what's clear is this, that over a period of 40 years, the practice is remarkably similar. Very, very interesting. And we've got the graphs, you can see them in the paper, but they're spread out over the time, and the average age is about 60. It's about 60% men. The interval between the primary and the secondary resection averages at 36 months. 60% of them are for solitary metastases, and 60%, unfortunately, are still dead in 5 years, in spite of what is highly selective in the published series, compared with what is much more liberal in the survey of opinions. So there's a big difference between the reasonably good results, 40% survivors, if you operate very highly selectively, and you let them all go loose, and you take on all sorts of patients.
So I think you've stated the case very well for a trial, and I think at the end we'll talk in detail about the PORMIT trial. Just wanted to go through a few other issues of metastasectomy, and some that I find sort of difficult, and maybe we'd like to start all the way back at investigations. Are all CT scans the same, or are there different quality of scans, and what about PET scanning?
Okay, so let us now start from a certain limited number of premises. One is that are you operating for survival or in some way to palliate? Well, the fact is it has to be to do with survival, because when colorectal cancer recurs, the patients do not become distressed by breathlessness. There's absolutely no reason to think that removing metastases improves present symptoms or prevents future symptoms, and indeed none of the 51 papers in the series tell us anything about symptoms. So we're talking about survival. The one interesting factor, that, and you've already mentioned it, is that there is a difference in the reported retrospective series between R1 and R0 resection. So I think you can start off with the general principle that if you're going to do this surgery, there's really no reason to think that taking some of the disease will make any difference. You're seeking to take out all the remaining colorectal cancer and getting clearance. There could be a debate about that, about reducing volume and making chemotherapy better and so on, but that's not the debate that's going on in these papers. It's to do with total clearance. Therefore, your imaging has to be as good as possible. And CT is getting better and better. There is a remaining debate about whether CT is good enough, and surgeons will find more by palpating the lung. If you look at Mark Ferguson's book on difficult questions in thoracic surgery, you'll find it addressed in a systematic review. The jury's out. But surgeons sometimes believe that they must feel the lung. Now, the interesting paradox there is the idea that VATS is a quick operation and therefore not too much problem with the patient. Well, now, the people who really believe in this are beginning to advocate thoracotomy in all patients so that they can feel the lung. Well, if you're going to advocate thoracotomy so that you can feel the one lung where you know there are metastases, you should be going in on the other side. And there's again another chapter in Mark Ferguson's very good book on this, addressing it, and again the jury's out. So you could be, if you're a real believer in the R0 resection, setting up every one of your patients for either sequential thoracotomy or even a cloud shell as some advocate. So this is a big operation for something which is a bit uncertain. Okay, so that's where we are with CT scanning and the scanning of the known disease or the known target organ, the lung. I think most of us, coming from a lung cancer practice, now have embraced PET. And the reason for embracing it is not to find out more about the disease you can see, although at a diagnostic level you might be interested, but it's actually to find out where there may be disease which you have as yet not seen. And in the case of metastasectomy, the rules are quite clear. If there is disease elsewhere, recurrence in the abdomen, retroperitoneal disease, disease in the liver, disease in the bones, taking out one or two nodules in the lung and the two nodules in your lawyer would be no point. So you must really work quite hard. And coming back to your example of the lawyer and trading cases with you, a patient was sent to me that they wanted me to take out the nodule in his lung. And they provided no information. I didn't know what the due stage was, it wasn't at all clear what the interval was, they hadn't done any of the other screening, so I sent him back to the colorectal team with a request to do this. Anyway, things went back and forth and I didn't get satisfactory progress, so I saw him myself. And he came in to see me and he said, look, I'm stuck between people saying I should have this out and you're not sure. I said, oh, that's different. He said, by the way, now I'm here, what do you think about this pain I'm getting here? There's no pain in my back. So, thanks to our wonderful modern technology, I was able to dial up a CT scan he had a few days before. He had a huge secondary in his vertebrae. So my hesitation was completely justified. However, I could see by the look in the poor man's eyes and his wife's that they had another view, that perhaps I'd wasted time and he could have been cured if only I'd operated on his lung. Well, you and I know that's not the case. He had a metastasis in his bones right from the outset, as he did in his lung. One grew and was able to be easily seen, the other wasn't revealed until he got back pain. And so the idea that you would just casually take out a couple of nodules out of the lung without the most meticulous search elsewhere that you can achieve is quite wrong. So PET, I would say, is essential.
So it'd be essential, and will that be a requirement in the pulmic trial?
Yes, it's a liberal trial in that people can follow local protocol, and the only aspect that they are expected to follow strict guidelines on is whether or not to do the metastasis by randomization. However, in the workup between the first consent for patients to enter the trial, this is the Mars model, a first consent where the trial is put to them and they have various investigations, assessments, conversations, and then a second randomization. We expect PET to be done in that interval.
And just honing you down again on VATS versus thoracotomy, in your own practice, what do you do?
Oh, I would always use VATS for an operation you can do with VATS. But that's partly because I'm a non-believer. Because if I really believe that feeding the lung made a difference and systematic dissection of the mediastinum made a difference, that is, I would cure people who were not otherwise cured, that would be a wrong practice. If, on the other hand, you're saying we're not absolutely sure what that nodule is, it might be a metastasis, it would be nice to have it on the pathologist's bench rather than still in that man's lung, I'd rather do that sort of procedure with the least harm and suffering to the patient.
So I think you've almost answered the question of what do you do in the mediastinum, lymph node sampling, lymph node clearance, or nothing?
Well, it's worth considering. Following the logic which we have been expanding, that total clearance is important, it would seem to be rather casual to me these days to not have investigated the mediastinum and perhaps not to have sampled it. There is evidence on that. There was a paper in the European Journal which I wrote a commentary on, and they found that 10% of their patients, this was from Leeds in the UK, 10% of their metastasectomy patients had mediastinal nodes, and I wrote a commentary pointing out that that was indeed likely to be true, and there was a series of other papers which all came out with about that number. I think if you let the whole disease run its course, it would be higher. So in this highly selected group where you think you've only got one or two, even then you've got 10% mediastinal disease. If you've got rampant disease, it's probably not common.
Yeah. And just a few other questions about sort of the metastasectomy. Sometimes they're peripheral, it's nice and easy. Sometimes they're very central. Is a pneumonectomy ever valid treatment of a metastasis?
I would say probably never, and it's been very carefully discussed in one of the papers, one of the chapters in the Journal of Thoracic Oncology June supplement, which is devoted to this. And anybody interested in this subject, I think that's a very valuable. We can talk about it a bit more, what's in there. But there's a chapter addressing that, and there would always be exceptions, because if you have a uniquely problematic case where the patient is in all other respects well but suffering some terrible symptom due to a single metastasis which you can relieve, that's rather different. That's the ad hoc judgment which you make about any palliative procedure. But as a policy, probably the severity of pneumonectomy as an operation in sort of sequelae is disproportionate to the good that you might do.
Absolutely, and as you say, that was a fantastic supplement, and we can provide a reference at the end of this video to that. And one other thing that jumped out at me that was a surprise is that the people that have done metastasectomy of over 100 metastases in the literature. And what's your record?
Well, I don't go in for that sort of record. That's Raleigh's work. And the point of that paper, and I think that's very extreme, it's 124, I think, and it makes me wonder, in the breast cancer, which we know is treated now as disseminated from the outset. So I do disagree with him about the rationale for that. My question would be, where's the 125th? But let's get back to what he's actually talking about in that paper. The paper is about a technique. It's to do with laser, and it is a means of getting out focuses of malignancy of various size, but with the maximum sparing of parenchyma while clearing the tumour. So if you are going to take out metastases from the lung, you do want to spare the parenchyma, and he's telling us how to do it. So I think, you must take from a paper what his message is. Now, if on the other hand we were liver surgeons and the liver regenerates, then it's a different issue. But for Raleigh, that's what the paper really is about, technique.
And there are lots of techniques of doing smaller resections, precision resections, laser and cryo and several other. Have you tried these, and would you like to see them?
Well, I've done. Yes, I don't mind what people do in the Palmic trial. We're not testing the method. We're testing the policy, and they must do the operation thoracotomy or with VATS, with the excision technique which is appropriate. Because you said before, what if they're central? Well, clearly, the answer of what you do with a big central, well, whatever size, a very central lump near the hilum and something sitting out on the edge of a lobe, clearly is a craftsman's judgment about how you take out that disease, sparing the most parenchyma and doing the least harm to the patient. Coming back to what techniques I've used various diathermy techniques, wedging, stapling and so on, and there are some very interesting tricks. But the answer is that people will use the technique or group of techniques which they're familiar with, which are well practiced in their unit. Otherwise it's silly, they'd be all over the place. I mean, life is like that in surgery. You pick one technique and you use it, having practiced it and getting the best out of it.
Is there a resection margin distance that makes you uncomfortable?
Well, if we get to the R0, R1 issue, whether that makes any difference in the totality of the disease, put that to one side. But it certainly makes a difference if you're going in there to clear this nodule. And I think you should have microscopic clearance. If you fail on that, you failed to do the operation you intended to. And probably to get that, I can't imagine that less than 5 millimeters margin is safe, because without that buffer zone, how would you know there isn't a little tongue of the tube sticking out? So I think that's probably the minimum, but that's a hunch. That's not been scientifically verified.
So what about the Cyberknife? It's going to put us all out of business, isn't it?
Well, again, go to the supplement. I mean, the people interested in technique, there's a section, a chapter devoted completely to the evidence for the various techniques, but the Cyberknife looks good. Because again, if you're going to do it, let's do it nicely and neatly, because inevitably, if you're going to wedge out with big staplers, you're wasting quite a lot of parenchyma that way. So it's an important consideration.
And I wanted to just talk to you about maybe some specific subsets of metastases. I'm never quite sure what to do with a CEA in colorectal cancer, and equally there's a beta-8-CG. Do you rely on these tests, or what do you think?
Well, the history of CEA is very interesting, and again, I've contributed a couple of little items to this supplement. Most of it has been from the ESTS working group, but that was one I couldn't resist dealing with. The carcinoma embryonic antigen became popular, well, certainly the early 1980s, and I was around when people were doing, my colorectal colleagues at the Middlesex in London, and in particular John Northover, what they called the policy of second look laparotomy. So the idea was you would do your primary colorectal cancer, and if you went back in again, you'd have a second go at it. And from that comes the whole issue of whether you take out retroperitoneal nodes at a second look laparotomy, whether you might take liver nodules out. The idea was that would be triggered by measurement of the CEA, so that you would have a group of patients, you do their CEA every 3 months or so, and if it bipped up, you go in and do something about it. Well, it turned out that it didn't make any difference. They all died at the same time in the end, but if they got a bip in the CEA, you knew about it a bit earlier and put them through more into investigations and interventions to no gain. And that was the colorectal surgeon's finding, not mine. Meanwhile, the word went out that this was a good idea, and it remained hovering around there, and so patients got sent to pulmonary surgeons. Now, the pulmonary metastasectomy literature is absolutely clear on this. Patients with a high CEA do badly, so we decide not to operate on them. So you have this curious historical accident of a disconnect of one group of clinicians using the CEA to send patients for pulmonary metastasectomy, and another group using exactly the same measurement to turn them down. So if the supplement does nothing else but clarifies that funny little disconnect between knowledge bases, it would be quite useful.
Yeah, yes, I found that very amusing. And,
Glad you saw it.
Yeah, absolutely. And so, moving on, I think you've alluded to it a little bit, but breast cancer, a lot of people say it's disseminated disease. Should we treat that a little bit differently?
Well, I think there are three groups of metastasectomies. There are the sarcomas, about which we could briefly discuss if you like, but they are a group. The germ cell tumours, which are primarily treated by chemotherapy, and we might have a role in checking if there's any life left, which would be quite a useful thing to help guide further management and inform the patient. And then the carcinomas in general. Colorectal cancer is the commonest by far for metastasectomy of all types, and certainly amongst the carcinomas as well. Breast cancer, you have to remember that in the early 1980s, out came an Italian trial which showed no survival advantage to radical mastectomy, and that changed the world of breast cancer. Because in my young days we did radical mastectomies, and surgeons were doing ever more radical operations in the belief that just a bit more would cure more patients. And it proved out to be wrong, and I don't think that tide has changed again. So breast cancer is regarded as a disseminated disease from the outset. And breast surgery for breast cancer is to do with local control. That's pretty well a given. It's not my subject, but I keep checking and they keep telling me the same thing. Therefore, what is the point in us taking out metastases at all from the breast, but certainly not in any large numbers? You know, I think there are times when there's a single metastasis occurs after 15 or 20 years, and in the breast you can get that. You can find them all over the place. And taking that out and getting rid of it so you can really look at it histologically, know what it is, maybe characterize that tumour, that makes sense. But a policy of breast cancer, well, it more or less makes sense, but a policy of routine metastasectomy in any group for breast doesn't really make sense.
And by that token, post-mastectomy, a chest wall recurrence, you'd leave that well alone, would you?
Oh no, that's different. No, a chest wall recurrence is to do with local control.
So
pulmonary metastasectomy, as we've already discussed, is not to do with palliation, it's to do with eradication of future cancer. At least I would put that argument to you, and if anybody will show me data of palliation, that's fine. But at the moment there are no data. And furthermore, just a little interesting point, so people will say, well, it gives the patient hope. We're doing it for psychological reasons. In the 51 papers, or anywhere else I've looked, I haven't seen any measure of optimism, psychological benefit, or any psychiatrists, psychologists, or other neurosciences. So this is a surgical notion that they're doing an operation for psychological advantage. I thought neurosurgeons gave that up quite a long time ago. You know, it's sort of not in our gift, certainly not in our knowledge base.
Yeah, there used to be a specialty called psychosurgery, I believe, for schizophrenia. Maybe,
yes, indeed.
Maybe there are a few psychosurgeons doing metastasectomy.
Yeah, well, and certainly obsessional states, disconnecting the frontal lobe, lobectomies, and it worked. They were less obsessional, but they went around letting their trousers down and embarrassing everybody and ruined their lives. You know, so
but as valid an operation as breast metastasectomy, maybe.
Well, let's not be so harsh.
Maybe not. And you mentioned, I mean, I found that a difficult one, germ cell tumours, where they're given chemotherapy, you go and you take the metastasis out and they say no known tumour. Is there any way we can avoid that, or is it actually a valid thing to take out burnt out tumour?
I don't know. I don't know, and time will tell, and I think it's a practice that will evolve. But there's certainly, you know, I have done that because I work very closely with oncologists as a chest surgeon, and there were areas where somebody would send me something which I didn't believe in, and I had reason to believe it should not be done. But with the germ cell tumours, I certainly took those out. And there was one young man we looked after over a period of time who had massive tumour at the outset, mediastinal shift, a terrible problem. And I saw him first, and between us, he went through quite a lot, and eventually I took out residual disease, which was clear, but improved the state of his chest by taking out a necrotic mass and re-expanding the lung and so on. And he is very well some years after, and they sent me little notes about him, and they're delighted with themselves. Now, whether my surgery helped the eradication of the cancer or not, I don't know. The fact that the mass was clear of cancer was a huge comfort to him. I'm not saying it's psychological benefit, but it was a comfort to him. And I think probably his hemithorax is better as a result, but those are all individual reasons why I don't feel too bad about that operation, that individual. It's a long way short of a policy.
Yeah. Okay, well, I think now it's probably time to move on to the pulmic trial, and I think it would be nice to talk about certain elements about it. And one thing I was particularly impressed about was your very innovative inclusion criteria, because it's not rigid at all, is it? I mean, I think that's fantastic and I'm sure it'll be a big help for recruitment. But do you want to just tell us about your inclusion criteria?
Well, first of all, it would be nice, as part of this package, I've got ready for you a flow diagram which we can have as an attachment for anybody who wants it. Basically, the view we've taken is this: there is a very wide spectrum of patients, and the spectrum is wide according to various dimensions, if you like, from one to many metastases, from normal to high CEA, from synchronous to long interval, and so on. Now, a patient might have one after a long interval or multiple after a short interval and so on. So these are linked to some extent, but they are separate. What actually happens is at present there is no consensus about how you would choose an individual patient. So what we're encouraging to do is people form their own local rules. Now, at one end, they may be quite unable to say no to taking out a solitary metastasis occurring after 3 years. And nobody wants to take out dozens on a patient who is barely recovered from their colorectal primary. But if they will say yes in this situation and no in that situation, we argue that there must be a turnover point of uncertainty. And exactly where that uncertainty zone is in this sort of multi-dimensional spectrum, if you like, and how wide it is, it's not for us to say, it's for them to say. So they can say yes or no to individual requests for metastasectomy, but if they're scratching their heads and pondering, we say, we don't know, put that patient into pulmonary. So that's the spirit of it. Now, there is one circumstance that we must not forget. If somebody has an undiagnosed solitary pulmonary nodule, you cannot assume that that is a colorectal cancer. Now, if it's a young non-smoking woman and it looks absolutely like a metastasis, you're probably right, and that would be okay within our trial. But if they've been a smoker and they're rather old, you cannot know. There are criteria by which you can make it judge whether it is more or less likely radiologically, but we would say a solitary pulmonary nodule must enter the solitary pulmonary nodule flow path and the lung team. So we're not interested in getting into our group patients who've had the wrong operation for a lung cancer. They should be considered in their own right, but can then rejoin the flow when we don't.
Yeah, because I suppose that would be a crime to miss a primary and breast metastases. Then more often than not they come as lung primary.
Well,
sometimes.
you know, it's interesting. In the course of working up the trial over 3 years, since 2007, when we sort of announced the intention in the BMJ, I've had lots of conversations with people giving lots of talks, and some said, you know what I discovered? In the last, it was a single figures, it was 8 or 9 or 10 or something. In this group of solitary metastases, they found a third, when they took them out, were primary lung cancers, not metastases. So if your mindset in the colorectal team is on, this must be a metastasis, you might be wrong. So that reminder has to be in the trial protocol.
And I'm sure one of the most common questions you get asked is how on earth do I persuade someone not to have an operation? And you've got a really good consent process.
Right. Well, the answer is this: there is a notion, and people even use the word "it is their philosophy" or "patients instinctively." But this isn't true. A completely naive set of patients don't have an instinct to invite you to cut their chest open. That's not their instinct. But if the word on the street is, bit of cancer, better out than in, you better get rid of that, then they very quickly believe that having something done is a good idea. But if you're realistic with patients, the next question they ask is, will this operation really help me? And if supposing you don't want to operate on a patient, because it clearly is completely useless, supposing it's a primary lung cancer, and you know there's widespread metastases, those patients don't insist on having a thoracotomy. If it's put to them consistently by, no, in your case an operation won't help, what we need to do, yes, thank you very much, doctor. So why do you believe that patients with a colorectal metastasis all want it out? It's not true. The important thing, and this is vital in the design of the study, is that the first person who sees them indicates that there is an option, and indeed uncertainty. So if I'm the first person who's met you and your lawyer 2 years after your primary, and the 2 nodules, I say, you know they do, slightly sad, and bleak shaking of the head. And then they use little words like a couple of tiny nodules. The tininess is neither here nor there. It's the point is they're recurrent cancer. But never mind. We'll send you to the nice Joel and he'll cut them out for you. Well, from then on, it's extremely difficult to say, well, we're not sure he's right, you know. Your doctor or nurse was right. You're backpedaling, and this is very hard on patients. So what we very much want people to do is this isn't a thing you discover in the presence of the patient. You discover it on the CT scan. You see the CT scan with the radiologist, and you say, what do you think it is? And the radiologist says what it is. So what are we going to do about it? Pulmic is what we would say. There is a trial for this. So what you say to the patient the first time you meet them, and this is the God's honest truth. There is a wide diversion of opinion on this. We're not sure what we should do for the best. And anybody who kids themselves that they do are wrong, because you've seen the supplement. It's very unclear. There's not one single writer in the supplement says the proof is there is an RCT, we know what we should be doing. They're all various versions of uncertainty. Hard to know what to do for the best. What we would like to do is for you to come into a study where we're looking at patients like you to find out what really is the best way to look after them. Now, because you'll have to have some tests and so on, most of which are routine, and we'd like to collect your data, would you consent for being within this study? Well, what are you going to do? Well, we don't know yet because we haven't evaluated. But it could be an operation, it could be not, it could be randomizing between the two. Okay, so they come in. Now, by the time that patient has been through, this could all be done within a day or two, or a week if it requires more tests. By the time they've had consideration of is this pulmonary nodule or lung cancer or not, maybe some histology taken with a needle if that's what you need, a PET scan and so on, the team can then say, I think we ought to operate on it. You know, I can't leave that single metastasis alone. Right, operate. We're not going to operate. Have you seen the state of his liver? It's all full of. But when they then see that this patient is in an uncertain group according to their local criteria, which, as I said, can be as wide or as narrow as they choose, you then say to the patient, you know, we're not decided. Sometimes we say a yes, sometimes we say a no, and it's hard to know for you. We'd like to allocate you to one or other by randomization, which you have to put to patients with considerable skill. Now, some of them won't want that, and but more than you might think. And as one of the chest physicians said to me, if you can randomise to Mars, you can randomise to anything. And we did. And we did.
Yeah, absolutely. And what will your outcome measures be?
Survival, but quality of life as well. Because supposing the survival were identical, but those who had an operation had more breathlessness, more pain in their chest wall, and so on, then you would advise against it. And conversely, if, to my surprise, patients who don't have operated metastases go on to have impaired lung function, and those who do are spared that would come out as a plus in favour of metastasectomy. But it's possible. The trial allows for discovery of a difference in survival and a difference in quality of life.
I think that's very important, the quality of life part, isn't it? So on the set of it, how many patients do you need? How many centres? And if people out there are interested, can they contact you and come in on the trial?
Yes, they certainly can, and we will find a way to get as many groups in Britain and elsewhere involved. In terms of how many do we need, it's very difficult to power this trial because our criteria are wide and we don't know quite who will go in. So the way Cancer Research UK and our UK cancer organisations are handling this sort of trial is what we call a feasibility study. And that is to say, you run the trial, but you accept that the power calculation is uncertain. And then you have to demonstrate that you're able to randomise enough patients at a reasonable rate. And of course, the power depends not only on the number, but the time you follow them up. So you need more patients to show a difference at 1 year and fewer patients at 5 years. But we're talking about getting 80 patients in within a couple of years. I don't think that would prove the case one way or the other, but would prove the trial could be run.
Well, it sounds like an absolutely fantastic study. And just one question I had in mind, this is obviously colorectal metastases. Do you think if you come out with a valuable answer, it's at all extrapolatable to other types of cancer?
I think absolutely. I think it is. I would have thought that if it's negative, breast would be the first one you'd say, well, if it won't work in colorectal, how's it going to work in breast? But at the moment, we're seeing occasional referrals from urologists with bladder tumours, from gynecological surgeons with uterine and ovarian cancers, and odds and ends of all sorts of cervical cancers. But if you look at what I call, I'm afraid rather, the partridge in a pear tree, where you go all down to one, and you get these sort of columns of numbers, whereas colorectal, and it goes all the way down, it's one of these, and two of these, three of one of those. And they're like that, and you can't gain any knowledge on them. But I would have thought that if colorectal is shown to be of limited benefit, or only a benefit in single, or whatever it is, that the same might translate. But it would be up to people to explore the literature and to see to what extent the cases who have had operations in the genital and urinary tract fit in with what we've found, and see if it does apply.
Well, I think that's been a fascinating insight. I think the pulmonary trial is absolutely fantastic. It's exactly what we need, and to have someone like you in the helm who's done all the background work on the Mars is absolutely fantastic. So from me and everyone at CTS now, I'd like to thank you very much for coming here and talking to us about it, and we'll perhaps give people at home your details if they want to get involved. And so I'd like to say thank you very much.
Well, thank you, Joel. It's been fascinating to discuss it with you. Thank you.
Thanks.